I'm Tom Hulsey, and I'm the moderator for tonight's webinar. I also serve as AUA News Patient Perspectives Associate Editor. My life was forever changed on my birthday in 2015 when I heard the words from my urologist that I had prostate cancer. Compounding my angst was the fact that I just witnessed my best friend lose his life to prostate cancer, and it was absolutely gut-wrenching. I attribute these past 9 years of my life to early detection. But as a survivor and advocate, I am passionate about utilizing my skills and experience to fuel positive changes that impact the health of our world. It's my honor to lead this roundtable webinar on the latest bladder cancer treatment trends. Low-grade, intermediate risk non-muscle invasive cancer accounts for approximately half of all bladder cancers in the U.S. The risk of disease progression is low, but the recurrence is high. TRBT is the current standard of care. This evening, I am continuing my discussion with Dr. Sandip Prasad and his findings in the Atlas study, and we're going to be joined by two bladder cancer survivors. Dr. Prasad is the director of surgical oncology and vice chair of urology at Morristown Medical Center and the Atlantic Health System. He is the lead investigator for the phase 3 trial Atlas. Dr. Prasad and I are joined by two other men tonight, bladder cancer survivors, and both are husbands, fathers, and grandfathers. Donald McNally is a retired sergeant in the U.S. Marine Corps and retired HVAC specialist and baseball enthusiast. He was an Atlas patient. John Ripka is a retired federal employee who spent 37 years with the FAA. Today, he does volunteer service and is with his local municipal government and several nonprofit organizations. John's bladder cancer was accidentally discovered during surgery during a partial colonectomy. John experienced recurrence in 2013, 14, and 15. But after his third recurrence, he underwent BCG treatments, and there's been no evidence of disease since. Annual surveillance is ongoing. But I would like to start out tonight's webinar by asking Dr. Prasad to just recap the Atlas study that was published in the 2023 Journal of Urology.
Well, thanks, Tom. And I wanted to thank you. I enjoyed our conversation from the last visit. I think today's seminar is a little bit different. I think this is really patient-focused. And I'm really excited to have both one of my patients, Donald, and a new patient that I've met today, John, both of whom I think have done very well by different means, to talk a bit about their experiences as well. I'm going to couch all of this in the context of the Atlas study, and I do want to thank the Atlas investigators who aided in performing this study. I also want to thank the AUA for putting on this type of program, and I would encourage the AUA to continue to have these types of patient-involved discussion along with physicians and other advocates, because I think this is actually a really needed resource for providers and for patients to sort of understand the community. And finally, I'd like to thank BCAN, which I think is the leader in bladder cancer advocacy for patients. And I will tell you, is an incredibly useful resource for me, where essentially every newly diagnosed patient with bladder cancer, I direct them immediately to BCAN as they first stop to understanding their new disease. So I know that John's going to talk a bit more about his experience with it, but I can't emphasize enough how important it is for all of these groups to meet together today. I'm going to talk about Atlas, and then I really just want to be a resource and a sounding board for John and Donald and Tom, and also for the audience. So please feel free to enter questions into the chat. It can really be about anything in bladder cancer. Today's discussion is really stimulated by a new study called Atlas that came out and was published at the end of last year. Atlas is, as Tom mentioned, a trial in a certain subset of patients who have low-grade but intermediate risk bladder cancer. And again, these are patients that are at high risk of recurrence of disease. And Donald will share his story with you as well. And we've heard about John, but bladder cancer, it recurs. And that's really the difficult part of this disease. It requires a lot of supervision, a lot of cystoscopy, a lot of intervention. And so any sort of treatment that can decrease recurrence rates is going to be very powerful for patients. And so we're looking at this particular subset of patients that are at high risk for recurrence, and really Atlas focused on those patients. This study was very unique in that it was a randomized clinical trial in surgery. So I really credit patients like Donald to allow us to study a resource where with the flip of a coin, some patients go to the operating room and some patients don't. I think that's a really special type of clinical trial. And I think patients who are willing to participate in those types of trials potentially allow us to transform the way in which we practice urology. But I recognize that it's not easy to sign up for a trial where you allow the coin flip to determine if you go to the operating room or not. So again, these are the most important trials in surgery and certainly in urology. And again, it may allow us to now have a non-surgical option potentially for managing bladder cancer. So the importance of these types of studies like Atlas can't be understated, and the participation of patients like Donald and the other 282 patients in Atlas. Again, those patients should be thanked for what they're willing to do to allow us to advance the field forward. So Atlas was a randomized trial. 50% of these 282 patients went on to say, you're going to get the standard of care. We're going to go in and just resect the tumor away. The other 50%, though, did something completely novel in the world of urologic oncology and certainly in bladder cancer. It was, I'm going to leave the tumor in place in the bladder, and simply by putting a substance into the bladder, I'm going to make that tumor go away. And that concept is called chemoablation. It's using a medication to ablate or destroy a tumor. And that is a completely new way of thinking about managing bladder tumors. Every patient who's had bladder cancer has undergone a procedure called a TURBT, which is a transurethral resection of bladder tumor. And that was the control arm of this study. That's what patients who were randomized to the standard of care underwent. And for bladder cancer patients, these are really familiar. But to the rest of us, this involves a procedure where patients have to go under anesthesia, and a tube called a resectoscope is placed through the urethra and into the bladder when patients are asleep under anesthesia. We then go and we shave away that tumor, trying to get down to deeper layers to make sure that we don't have any invasion of the bladder tumor. And then we use heat to cauterize or burn that remaining tissue so it doesn't bleed. Clearly, patients who are at risk for bleeding, such as those on blood thinners, we worry a bit about the recovery of that process. Plus, we put instruments into the urinary tract, and that can be uncomfortable. Many patients after this type of procedure require a catheter to rest in the bladder for a day or two, or even longer, to allow the bladder to rest. So while the procedure may be short, meaning it's 20 or 30 minutes, there's a lot that's involved in taking a patient to the operating room for this, whether it's pausing blood thinners, getting the cardiologist to clear a patient, and then the management afterwards. So this type of operation is unfortunately also repetitive, meaning that when patients recur, we continue to offer this type of resection. And John and Don are going to talk about their experiences because they can speak much more honestly and frankly about a TURBT than I can. But obviously, having taken care of thousands of patients that have gone through this process, I can tell you that nobody particularly enjoys it, but it's a necessary evil of managing bladder cancer historically. For the patients that were randomized not to resection, these patients had a special gel put into the bladder. And this gel basically allows the covering of the inner lining of the urinary system to be coated with a drug called mitomycin. We've been using mitomycin in the bladder for decades, but we've used it in basically water. And so what happens is it sits in the bladder, but the first time that you pee, you urinate out all the mitomycin. And so the contact time that you get where this chemotherapy can actually touch the surface and begin to interact and kill cancer cells is limited basically by how long you can hold it. And for most patients, that's an hour or two. The gel allows for sustained contact because even if you urinate, the gel still sticks to the lining of the bladder. And that's really what makes this particular study drug unique. And so we put this into the bladder via traditional catheter. So a catheter is placed, the gel is instilled into the bladder, and then the catheter is removed. That whole process is about 90 seconds to 2 minutes or so to do. That's done in the office and done without any anesthesia. And in general, that process is mildly uncomfortable, but the catheter remains in place for just a minimal amount of time to allow the drug to be put into the bladder. And then patients go home and they urinate out at home, and they'll begin to see the drug be excreted 6 to 8 hours later. So it allows for contact time that's far superior to what we could do with just the type of mitomycin we've been putting in water historically in the management of bladder cancer. And so what we looked at was if we take half of patients and resect out a tumor, remember, and these are patients for whom we know it comes back more frequently, and the other half, we go through and we put the medication into the bladder, how did they do at 3 months? And 3 months is a special time, as both John and Donald know, because that's the interval in which we look. And so for patients with bladder cancer, we're typically looking in their bladder every 3 months. And so that's a pretty frequent interrogation, but that's the timeline in which we typically use to assess if something's there or gone. And what we found is that essentially the two were basically equivalent, with the study group being a bit superior. So patients who had what's called a complete response at 3 months, meaning no tumor was seen in the bladder, was 65% in the study group with the gel and 64% in the TURBT group. So some of those patients who had their tumor resected had a tumor come back by 3 months, and that's kind of how this disease behaves when we don't give other treatment. And so while those two numbers are very equivalent, it's really sort of astonishing in a way that for a patient who never went and underwent an operation to remove a tumor, they basically matched at 3 months being disease-free. And so I think even though, you might say those numbers are equivalent, to me, that's incredibly powerful that we have another option that's as equivalent to putting a patient under anesthesia, stopping their blood thinners, getting cardiology clearance, putting them through an invasive procedure, and potentially a catheter afterwards with something that's based in the office for just a few minutes. But even more importantly, we looked long-term and said, how did patients do when we followed them over time? And the idea here is that perhaps a gel that coats the whole lining of the urinary system is actually going to provide protection and kill even those small tumors before they even begin to arise in a way that we can see them. Because when we do a TURBT as a urologist, we have to see the tumor to remove it. And while it sounds obvious, it's not always that easy to see. There's little nooks and crannies in the bladder. And again, there's changes that occur in a man or woman's bladder over time that may make something look a little bit irregular, and we're not sure what to do with it. And so TURBT is pinpoint. It's to identify a particular spot and remove it and eradicate it. The gel is different. The gel coats everything, whether you see it or not. And so what we found, not surprisingly, but I think in a really meaningful fashion, is that patients who were treated with the gel, when we followed them out to about 15 months, there was a 55% reduction in recurrence, progression, or death in patients who had the gel compared to patients who had the TURBT up front. And so patients who had the gel had superior long-term outcomes, even if they had a TURBT down the road after the gel was administered. There seems to be something protective about giving something to what we call the field, meaning the entirety of the lining of the bladder appears to be protective. Always, it's important to talk about side effects because treatments can have side effects. And so the first thing we look at is something called serious adverse events. These are things that bring patients back into the hospital, require subsequent operations or treatments. And we did not see that in the study group, which is fortunate. We did see an increased risk of side effects, though, in the group that had the catheterization 6 times compared to the patient that had just a single TURBT. We did ask those patients more often about side effects, but they did report them more commonly than they did in patients who had TURBTs. And those are things that we typically see in urology and that patients like Donald and John may have experienced. So things like blood in the urine, urinary frequency, urinary urgency, burning, that appear to be a bit more common, but in what we call grade 1 or grade 2, I mean, the types of things that patients report but may not take any additional medications for, or patients have sort of time lapsed and they feel better about it. So again, I think the side effects for the study drug are reasonable and they're safe. They may be a bit increased because patients are getting a bit more in the way of catheterization. And both John and Donald can talk a bit about more of that in detail, but there were no serious adverse events. Finally, I would talk about the next trial that is hopefully in place to potentially allow this drug to become approved, because it's still a drug under study. So I've had patients reach out to me and providers reach out to me, hey, I have a patient I think would be really valuable for this. They keep recurring every 3 months, even though I'm doing my best to try to resect them. I've sort of run out of things to do, but this is still a study drug. It's not FDA approved, but there is another study that followed up with Atlas called Envision. And this looked at a subset of the patients that recur the most often, patients that recur within 1 year. So these are patients that are getting a lot of TURBTs. And what they found is at 3 months, and that's all the data we have to date, at 3 months, 79% of these patients had no tumor and did not have a resection. So almost 4 out of 5 patients without surgery had eradication of their tumor at 3 months. And so I think that's really powerful data. For Envision, we have to wait for the long-term data because that's really important for patients to understand. Is it a treatment that's going to work for a while? And I think as the urologist talking to a patient, I need to both tell you what's going to happen in the short term, but also, is this worth it in the long run as well? And so Envision is closed to new patients, but patients are still in follow-up. I just saw and did a cystoscopy on a patient today who is at her 15-month Envision follow-up. So again, as those data begin to roll in, we'll hopefully hear from the study group about results, and then the possibility of this product maybe getting FDA approval and then be able to come out to other patients. So it's a really exciting time for bladder cancer. Atlas, I think, is a really important part of the journey that bladder cancer is making towards being less invasive. I want John and Donald to kind of give us a little bit of a narrative of their history. Tom, I'm going to let you sort of take back over, but I'm happy to jump in anytime you'd like.
Well, thank you, Dr. Prasad. It really is encouraging and exciting what you're doing and the potential from a patient perspective, from what I can gather. But I would like to hear first from Donald, your experience as a Atlas patient, and just your thoughts on it.
Well, the whole experience that I had going to Garden State Urology and visiting with Dr. Prasad, I was always comfortable, well-informed, and I was very pleased with that. Always felt very comfortable, and so that was pleasant for me. And as far as the treatments, the cystoscopies that I had every 3 months, they went very well. Very comfortable, and well informed, and so I was very, very happy. And once I had the product delivered, I had that nice cool feeling. It was refrigerated, but I felt very well after that. As far as side effects, I'll be perfectly honest with you, I almost had none. I would say that following each treatment, about 2 days, they were 5 days apart, I believe. Or a week apart, about 2 days after the treatment, I would get a head to toe warmness and rash. My skin would get a little reddened, and I'd be tingling from this rash. That would last typically for about, I would say, between 45 minutes and an hour, and that was it. Just 2 days following the procedure, this would come over me and last for about, like I said, 45 minutes to an hour, tingling and itchy, but not feeling bad at all. Didn't feel very well. So my experience with from day one till it was completed, I'm very, very happy with.
And Donald, you had BCG prior to this as part of your treatment. I know you were diagnosed back in 2017, so congratulations. We're getting into 7 years.
Yes.
It's been disease-free for some time since the study.
Yeah.
You've never had a recurrence, which is great. Can you tell us a little bit about BCG compared to the study drug? Because they work a little bit differently.
Yeah. Well, BCG, of course, was done in the office, in my urologist's office, before I joined United Urology, I didn't have much of anything that prevent, something to soften the blow, so to speak. Yeah, it wasn't bad. It was pretty quick. I was in and out pretty quick, and poking around a little bit. But I did feel some discomfort there, but it didn't take any time at all, really. And the results from the BCG, I believe, were pretty good. I did get a phone call from Dr. Giannis at one time, and he told me that he had real good news. So he said, great news. I said, oh, good news. He said, no, I'm talking about great news. He said, everything is okay. That whatever they were looking at was benign. It wasn't cancerous. So I was happy with that. But then I joined Garden State Urology, I think 2021. So I was 4 years with Dr. Giannis in Summit Urology. I'm so happy that I did join Garden State Urology. I really, the experience has been terrific for me. I'm very comfortable. And they explain everything to me. I had really no questions. And the procedure was terrific.
Thank you for sharing that, Donald. I'd like to shift over to John now as someone who did not participate in the Atlas study. Could you share a little bit about your bladder cancer journey?
Yeah, my journey started in 2011, and it was kind of found by accident. I was having some issues with diverticulitis, so we went in for some exploratory surgery to find out what was going on. The surgeon used a urologist to put stents in the ureters as a precautionary, and we ended up finding out that something was going on. And I was waking up the next morning after the surgery, and it happened to be that the hospital help entered the room to pick up the trash and let it out. And she goes, "Hey, did you hear about the young man who came into the hospital yesterday for a surgery and now he's got cancer?" And it's like, I'm talking small town, small hospital kind of thing. And when my wife came in later that morning to talk to me, like she was white as a ghost, wouldn't say a word. So I knew something was kind of up. And then the doctor came in later that afternoon and said he saw something. He went and looked at the CT scan and sure enough found the bladder cancer. So that was in 2011. Following that, 7 days later, I had my first resection to URPD. And I thought everything was okay. I can tell you that I was scared. My personal experience with cancer was watching my father pass away in front of my eyes, 18th birthday. So when you hear that, you just freeze. I never heard of bladder cancer. Nobody in my family had bladder cancer. So I said, okay, we'll follow the orders from the doctor, cystoscopies every 3 months, and we did that religiously. I would add that it was a contributing factor of me retiring when I did. So I retired in 2013, and I had my 37 years in, and it was like spending 2.5 hours a day in a car around DC traffic. I said, why am I doing this? All right. So I retired, and sure enough, 6 months later, I had a recurrence. And that's like, well, that was scary. So, and even though it's maybe intermediate grade, you think the worst, right? You're saying, is it more aggressive? What's going to happen? Am I going to lose my bladder? You can't not think of those things, even though it's just, resection, resection, resection. I remember asking my surgeon, I said, how many of these can I have? And he just said, lots. It's like, I don't want lots. I wanted something to, do a little better, or maybe try to address a little more. And so after 2013, and that recurrence, it wasn't a year later in 2014 that I had a recurrence. And it was like, okay, is how it's going to be? Every year I'm going to have a resection for year after year after year after year? Is there anything I can do to not go through this? And it was like, didn't know. So another year, I had another recurrence. And it was like, what do I do now? I mean, and you're thinking that every time you have this recurrence, is it going to get worse? Is it going to get more aggressive? Do you have to do something more? And again, you talk to some people in the community, the bladder community, and you talk to the folks where it has spread all over and they had their bladder removed and how they're coping with it. It's like, gosh, I don't want to go through that, but you can't not think about it. It just goes through your head. So after that third one, my doctor said, hey, let's try BCG treatments. So we did the initial 6 inductions, and then probably had 3 more every 3 months. So it's about 15 bouts. And knocking on wood, I can say that I've been no evidence of disease since. That doesn't mean that everything's okay. You're going to have, annual cystoscopies for the rest of your life, probably, but at least it kind of cured it. I would say that it took me 8 years from 2011 to get to the point where I could just have an annual cystoscopy. And that was a long time. Every time you do a resection, you have to go back to square one. It's like playing Monopoly and going to jail. You have a resection, you have to go back to your 3 month cystoscopies. I've had 28 cystoscopies already, and it's like, wow, I'll probably have a few more, in the future, but quite a shocker. And in 2013, just as a sidetrack, and one of the reasons I'm going to bring it up in a minute, but after my first recurrence, 3 months later, I was diagnosed with prostate cancer. And so here it is, over 10 years later, and now my PSAs are starting to act up, which means they didn't catch it all. It's microscopic. How do you catch it all when you do the surgery, right? And the thought of instilling a gel into the bladder where it covers everything and you don't have to worry about it, it's kind of kind of promising. You know, blue light cystoscopies are great, but you're still not going to catch it all. If you could chemically somehow put it all through the bladder and let it soak in a little bit and through time and hold it longer than the 1 to 2 hours for mitomycin C, I think it's very promising.
So you really answered I think my second question. And what is your impression as not being a patient on the Atlas study? What are your impressions of the study?
Had it been around in 2013 or 2014, I would have jumped at the chance because I didn't know what else there was. I didn't know I even had a BCG option at that time. So all I could think of was resection every year. Oh no, is it going to come into 6 months? And how can it grow that quick? And how often do you have to have these things? I mean, it just goes through your head and just spirals.
And I think, you know, you really point out something really important, John, is that these TURBTs, even though, you know, you had an extraordinary number of cystoscopies, I think TURBTs are different, right? Cystoscopy,
Yes.
You bite your cheek, you get through it, and then you know you're okay. A TURBT, there's sort of a hangover component to it. There's a preparation component for it. Donald's a very, very healthy, you know, fit, but also an octogenarian, right? And he's in great shape. But, you know, as you get older, we don't love the idea of putting patients under anesthesia. It's not probably good for you. And so when we have to do it, we do it. But anything we can do, whether it's BCG in the office, whether it's these hopefully new topical therapies that don't do that, every single time you can get a cystoscopy that's negative, I think most patients are going to sign up for anything in the office, like you both have, BCG for both of you, and then obviously the trial for Donald, to be able to avoid that TURBT experience. And so I can tell you, I have my own worries when I have a patient who's had a heart attack and a stroke and a new cardiac stent, and they're on a blood thinner that's the first time they're ever coming off their blood thinner. It makes me a bit nervous too, but we have to do it, right? We have to get these tumors out. We can't give them a chance to invade, or if they're large, sometimes they start to bleed. And so taking the complexity out of this, patients with strictures and scar tissue, patients with blood thinners, older patients, the average age for bladder cancer is 75. Many patients have a history of smoking. That's one of the risk factors for it. So some patients have heart and lung disease that comes along with this. So I think, like you said, a cystoscopy, you kind of sign up for it, right? But a cystoscopy is different than a TURBT.
Absolutely.
And so I think, you know, you both have painted it very well because of your own personal experiences. And so I don't look at anything as replacing TURBT in a way, because in the very beginning, we kind of have to know, is it a low-grade tumor or a high-grade tumor? So we're probably never going to stop doing TURBTs. But the question is for patients with low-grade disease that keeps recurring, like John, you so nicely described, and each time it's kind of a wallop. Even though we tell you, hey, it's okay, it's low grade, it still doesn't feel great, and there's still a plan to go to the operating room. I think that these types of treatments can really offer a different pathway for patients. And again, for me, it would be, you know, when you're talking about a response rate in our highest recurrence rate patients, of which you would have been, John, you would have been one of them in Envision because you recurred within a year more than once. 79% of patients had no resection and had no tumor, right? So it's sort of hard for me to imagine if those numbers really hold up in the long run, why wouldn't we give it a try first in most patients, right? And there'll be some patients for whom that may not make sense for other reasons, transportation, you got to come in for it. But I think just having another tool in the toolkit is going to be really impactful. And I actually think, and it's interesting to hear you talk about it, and I have other patients who, of course, know about the study. It's probably the treatment that I've heard patients ask about the most. Because I see bladder cancer patients so often, they're always like, hey, Dr. Prasad, did that study finish that we've talked about? Because I think patients are sort of awaiting it. And I think that's really different. It's a treatment that patients are going to drive because of their own long-term experience that the both of you have had. You're talking about 20 plus years of bladder cancer surveillance between the two of you. And you're going to do it every year for the rest of your lives, right? And I think patients are going to drive this. And that's really, you know, I'd love for you to talk a bit about BCAN and what BCAN does for patients, because I'm a huge advocate for it. But again, another place where patients can hopefully find this type of resource to learn about what they can ask their urologist about, because it took you 3 years to get to BCG, but I would tell you, I would have done it within the first recurrence, right? Because that's the pathway. What you kind of had for a few years is what most people have. And so if you don't mind telling us a bit about BCAN and kind of what it's meant to you. Clearly you have the shirt on. I know you're an advocate for
yeah,
it.
no.
But talk to us a bit about it and the way you think that patients can interact with new therapies, whether it's the UroGen Atlas product or others that are coming down the pipeline. How do you see Beacon helping us?
I mean, I think the world of Beacon. I mean, it helped me so much just trying to find out what I was dealing with. You know, you can Google all the sites out there, you know, government sites, etc. And it's like, okay, I get it, but I really want to know what it really means. And when you can meet the people over there who's got this and talk to them about experiences, it's worth its weight in gold. It really is. And I think Beacon, if they could help solicit some people for these trials, I think it would be fantastic. I was kind of shocked that the study was stopped because not enough people who said they would join it actually joined it. And
Yes.
it's like, you know, I would do it just to advance the science and tell the truth over there, but it's like, darn. So when I was going through all this stuff, nobody said anything about any kind of trials or anything that was going on at the time, right? Which meant there was no other options out there to deal with. But I mean, they could certainly be a catalyst.
Yeah, so it's interesting for Atlas, you point out something. So the study did end early. It ended early. One, I think, is you're right. It's hard to get patients, as I mentioned at the very top of this, to flip a coin and be willing to go to the operating room or take a medicine, right? That's kind of leaving a lot up to a flip of a coin when you're talking about your own body and the choices that you get to make. So you're right. I think these types of studies are hard to accrue. But the company, I think, identified that there was an alternative pathway where every patient could get the drug. So in Envision, there is no randomized group. Every patient who had recurrent bladder cancer that was low-grade intermediate risk could get the medication. And that study accrued in like less than a year with the same number of patients, right? Because it's funny, for this study, every patient entered it with the hope that the coin would flip away from TURBT, right? Because everybody who entered the study wanted to be in the study group to not have to go through another TURBT. So I think there's a lot of combinations as to how the company decided to end the study early. I think they were pleased with the data, that they identified that there was a great long-term benefit and it was at least equivalent in the short term. And then they saw the opportunity to potentially have a study where everybody could just get the drug. And that's a much easier study. And I could tell you basically every patient I approached who was interested in the study signed up for it, right? Because it wasn't sort of this coin flip of randomizing to surgery or the drug like Donald had to go through, right? A chance that he wouldn't get the drug, but have to go through TURBT. For patients who are on Envision, the second study that's not finalized yet, but we just have the preliminary data, all those patients could get study drug. And I think it was kind of that pivot to that new study. And that's the one that I hope, I don't work for UroGen, but I hope that's the one that will allow for submission to the FDA to allow this potentially to be in the hands of every patient.
Yeah. There's also the cost of those resections, TURBTs. So the last one I had in 15 before I started BCG, they billed out $10,000. And not everybody has, you know, the kind of insurance I have. That's why it's like, wow. You know, even cystoscopies, you know, the costing $3,000-$4,000 nowadays. It's like, if you can get rid of that, all the better.
Yeah, I mean,
you know, slow it down or whatever, defer some of it.
You bring up a really important point in medicine and really specifically in cancer care, which is what we call financial toxicity, right? The idea that we are putting patients as part of their disease treatment, we are putting financial burden on these patients. And I think we have to be cognizant of that, right? Like you said, patients are great. They listen to their doctors for the most part, and we try our best to, for the most part, do what's clinically necessary and clinically important. We don't want patients to do poorly from a medical standpoint. But you're right. I always think about the financial toxicity. And so when we talk about treatments, you know, how are new treatments going to be priced? I think that's really important for us to make sure that patients are aware of this, that as we have something new. And again, this particular product is still under study. We don't know what it's going to be, but you bring up a really important point, especially for a disease like this, that you're going to see your doctor for the rest of your life. Hopefully just once a year for a few minutes to tell you great news. But you're right. You never let go of bladder cancer. And it's the 6th most common cancer in America. Right. So people may not talk about it the way we talk about breast cancer or prostate cancer, but it's extraordinarily common. And that's why it's great for you and Donald to really advocate for patients who have bladder cancer and for BCAN to be a resource for those patients to find a place, because really there's so many of them out there. And again, you're patients who survive for a long time, hopefully, but you still remain bladder cancer patients, right? We don't just talk to you about your bladder cancer. You still have to go through the cystos. So really important to think about those issues long term.
So next year in 2025 will be my, I'd call it 10th anniversary, right? NED. And it's like, can I ever say I'm cured of bladder cancer? Because nobody ever says that to me.
What I tell patients is you're cured till proven otherwise.
There we go.
I think that's what you are. And I would tell you it's not wrong to say you're cured because you have gone many, many years without bladder cancer, but you got to watch it. It's a disease that can come back, but it's not coming back because it's been missed, right? You've had a long enough time to know if we missed a small spot, it would have grown back by now. You know that from your own experience, right? It took just a year to form a new tumor. There's something about BCG that transformed your body's ability to change the way it fought off these tumors and now put you kind of in this new circle, which is you can do this on your own. And so I think it's okay to say you're cured, but you got to get watched, right? But I think you're cured. We don't, cured till proven otherwise is kind of what I tell patients, because I don't want you to feel like something terrible happened to you. This disease does recur. You guys both know that from your own experiences, but I think you should also celebrate the victories, right? The fact that you annual cystoscopy, not every 3 months like both of you have had, where we're looking in with intensity. You're going once a year and hopefully just spending 5 minutes with your urologist and then giving you kind of another great check for the following year. You should celebrate that.
Dr. Prasad, you had mentioned, I had my notes here. I was going to ask you a question. I apologize. Donald, go ahead if you were going to ask him something.
No, I'm sorry. I just agreed with what was said.
Well, I was going to turn it back to you anyway. How has this study and your involvement impacted your life and your quality of life, Donald?
Well, of course, the last year has been wonderful for me. I haven't had to, get a cystoscopy or anything. So it's really lifted me up. I'm going to be 88 soon. So I feel great. I'm very confident in what was done for me. And I appreciate everything that was done for me, Dr. Prasad and the treatment. But yeah, it kind of changed me. I don't know if it changed my life, but it lifted my spirits up a little bit, knowing that I didn't have to come back for a year. I was shocked to hear that. Coming back every 3 months, something I got okay, but when I was told that I had a whole year, I was like, oh my God, this is wonderful. So I certainly enjoyed the year and looking forward to many more years.
John had mentioned about the term, being cancer-free versus NED, Dr. Prasad. Isn't it that way with any cancer? The longer you go from the last occurrence of it, the chances of recurring diminish?
Yeah, it's an interesting, so bladder cancer may be a bit different than that, right? So I agree with you. There's certainly diseases where we see low recurrence rates within a particular organ. So for example, let's take kidney cancer, something we treat in urology. If you have a cancer arise in your kidney and it's removed with a negative margin, for example, the cure rates are like 95%. And the risk in your lifetime of another spot coming back is in the low single digits, like 2-3%, right? So for those patients, they're probably cured. If you have a negative margin at surgery, I tell that patient, you've got an exceedingly high cure rate for the rest of your life. And in fact, we stop following those patients after 5 years, right? They don't have to see the urologist anymore. I mean, they're done. They can go about their way, because again, we're following those patients for 1 in 100 that may recur. Bladder cancer is a bit different. There's something inherently about this organ that has like a propensity to recur. And so unfortunately, Donald and John, well, again, I'm happy to tell you, you are cured till proven otherwise. I think that's not a scary word to use. NED is no evidence of disease, but I think you have changed the way in which your bladder now behaves. But we got to watch it, because there's something about this disease that has some inherent recurrence. But you've kind of like turn the switch on the train track, right? You were on a certain train track, you deviated off it, you're on a new train track, which again, you're going to hit 10 years. Donald, you're on annual cystoscopy now after many years of being very frequent cystoscopies. But there's probably something different about bladder cancer. And, we don't know why that's the case. It's probably something to do with the fact that the bladder is the reservoir for urine, and urine's all the stuff that our body wants to get rid of, right? That's the bad stuff that you're trying to excrete. And so the urinary system kind of pays the price for the whole body, in that all the things that are the toxins or the chemicals that we don't want in there, they go out of the urinary system, but they sort of sit and bathe in the lining of the bladder before you pee it out. That's just how the urinary system works. So the bladder kind of pays the price of having to hold all this stuff that we don't really want in our body for an extended period of time. Again, we don't always know why that's the case, but that's why, like John had referred to that field, why a drug that coats everything may be beneficial. It's also because the urine kind of coats everything, right? All those substances contact everywhere as well. And so, again, we have to watch bladder cancer differently than other cancers, where I do discharge patients from my practice, where I'll say, you had a cancer, we observed you closely to make sure it had not jumped microscopically, but after 3 years or 5 years, you actually don't have to see me anymore. There is no more testing. Bladder cancer just doesn't have that in it. But I tell patients once a year, say hi to me. I'm a pretty nice guy. We'll visit for 5 minutes. I'm going to give you great news, almost certainly, and I'll see you in a year. And I think, most patients, that from where they start, if that's where they knew they were going to end up, I think it's okay. And again, I would ask Donald and John to speak to that now that they're there. But I think from where you start, when there's just so much worry about the bladder being removed and bleeding and this unknown process, to a comfort to the point where you guys are both here talking about it. I think when we can get patients to annual cystoscopy by reducing recurrence and progression, whether it's BCG, whether it's a study drug, or any of the other tools that we have, this is where we have to get patients to, where we're at yearly cystoscopy that goes quickly and is easy, and you just get to move on and enjoy the rest of the year.
And there's a little thought that's always in the back of the head that even though you've been cleaned for so long, that you're always afraid that the bladder cancer will come back higher grade, more aggressive, and you got to start it all over. I mean, that's something I try to suppress in my mind, but every time you go through your annual cystoscopy, that's what you think of. I mean, you're watching the doctor's reaction as he's scoping you, right? And you're going through in your head, what's he seeing, because you may not have a monitor up there. Some hospitals do, some don't, but it's like you just kind of sitting there just waiting and waiting and waiting and looking for facial expressions from it to try to figure out whether you're good to go or not. I mean, it's and the other thing that kind of passes my mind is even with BCG, if that is a treatment for recurrences for intermediate risk, I mean, there's been shortages for years now. I mean, it's up and down, up and down, up and down. And how nice would it be to have another option?
Yeah.
Right? So even if you have a BCG treatment, it's only 50%, if you're lucky, right? I mean, wouldn't it be nice to have something that produces the kind of stats that your study did?
Yeah, and the nice thing about BCG and the study drug here, which is using mitomycin, which is a chemotherapy agent, is they really work by different mechanisms. So kind of to your point, if one is not completely effective, the other one may very well be, right? Immunotherapy is different than chemotherapy. Immunotherapy is using your body's own immune system and targeting it. That's what BCG is. It's been a stalwart for decades and decades in urology, but it doesn't work for everybody. And chemotherapy is about the medicine itself destroying the tumor directly, not using your body's own immune system. So for patients, for example, where their immune systems are not strong, which happens to all of us as we get older, but to people who have other medical conditions, for example, those medicines are not effective when we use immunotherapy. And you've got both, potentially have both in the armamentarium. The other really interesting thing about the Atlas study drug is BCG we only use in the adjuvant setting, meaning we use it after we remove a tumor completely with TURBT. Then we wash the bladder with this medication to prevent recurrence and progression, to use this immunotherapy, your body's immune system, to come in if a new small tumor is forming, that it can kill it before it grows, and is something that we can see. And BCG is pretty effective at doing that. This study drug is actually primary therapy. This is competing with the TURBT itself. You don't have to do that first, potentially, right? And so could there be an instance where you do that first, maybe it gets smaller or goes away and you do BCG after, and you've got this 1-2 punch now of two novel ways of getting patients to that yearly cystoscopy quickly, where you're not having that concern for recurrence, because you're never going to forget your journey, right? You're never going to forget that feeling of having someone tell you something came back. But the sooner we can use these types of agents that have what appear to have very safe profiles, is to put patients on a quick track to yearly cystoscopy, not have that recurrence experience, not have all the resections that lead to scarring and sometimes some voiding issues over time. But I think you're right. I like the idea of whatever we have, give the urologist more tools so patients get more tools. And I would encourage you and Donald and all the patients who are out there, you can advocate for yourself. When these drugs become available, BCG is tricky. It was so popular that now we have trouble with shortages because of manufacturing issues, but every doctor knows about it and we all want it in hand. And so these new agents that are coming out that hopefully the FDA will approve, and there's many that are coming out, it's important to keep asking your doctor, hey, what's new, what's out there? And I think the AUA and BCAN and other groups can really advocate for patients by making sure that these things are front of mind, that you know about the studies that are coming out so you can ask about it. And so, I think that you're going to see, let's say in 3 years, probably 2 or 3 new and different ways. We have gene therapy that is now approved in bladder cancer, right? That's for patients where BCG doesn't work. And so, again, we're talking about sort of the newest types of treatments that exist in the world we're now bringing into bladder cancer. And so it's just a really exciting time. And I think for patients who have bladder cancer, keep asking the doctors, keep going to the Beacon website, seeing what's new, going to the AUA website, the American Cancer Society. There's a lot of great resources out there, and say, what's new for me? What's something that I can do for prevention, for recurrence and progression? Because you're going to find this change over the next 18 months to 3 years. It's going to be a completely new playing space. And the BCG shortage has driven a lot of it. We have to have new things because we can't always get BCG anymore. So, it's a really exciting time, I think, for all of us.
Thank you. Well, it looks like we do not have any questions in chat, but I just wanted to kind of wrap things up and see if Donald or John have anything else they would like to add. I mean, we really appreciate the patient perspective here. Obviously, this is near and dear to my heart, and being your own best advocate, as Dr. Prasad said, is so important. But do either of you have anything you'd like to say in closing here?
No, I would offer that when I was involved a little bit more with BCAN over there, we actually did or tried to get a grant to study anxiety and discomfort associated with cystoscopies. But having had the prostate cancer and the gland removed, I can tell you that cystoscopies are much more able to be tolerated without the gland there and the sphincter going right on through. But yeah, it was fantastic. And again, I can't say enough about the BCAN. And all of these trials that came up, we actually put them on the website out there, so people can go looking for it.
Donald, do you have anything you'd like to share in closing?
Well, except that I am so appreciative of the treatment that I've gotten. I feel blessed that I was lucky enough to participate in this study with Dr. Prasad, and I have all the confidence in the world in Dr. Prasad and the new studies, and just looking forward to the future. And whenever Dr. Prasad would like to see me, then I'll be there. But no, I feel very good. I also did very well. I had prostate cancer in 2010. I had the CyberKnife treatment, and that was so wonderful and so quick. Just a half hour for 5 consecutive days, and it was over with. But between the two of them, I am just blessed to have the treatment that I've had, and I'm so happy about it.
Tom, I had a question from the chat. I think it actually just came to me directly from a doctor, if you don't mind if I answer.
No, go ahead.
Yeah. So the question is from a Dr. Smith. It says, as discussed, this seems like a great opportunity to change the paradigm. Oh, I think you just added another question. The paradigm of treatment for bladder cancer. Is there an opportunity for private practice physicians to participate in trials as this therapy seeks FDA approval? So I'm a private practice physician. I initially began my career in academics, and I transitioned to private practice about 7 years ago. The reality of non-muscle invasive bladder cancer is that the majority of it is treated by private practice physicians. This is the type of care that is given throughout the community. Academic centers are terrific, and they often deal with some of our most complex diseases. But non-muscle invasive bladder cancer is kind of the disease that is everywhere in the United States, and typically actually is treated by private practice physicians. So I'm one, and I would tell you that there are many on studies that allow for participation. So if you're interested in that, feel free to reach out to me directly. But many companies that are organizing studies want to make sure that we sample broadly from the experience across the country. And again, private practice physicians, we often are the ones that sort of do the most representation because there's not an academic center evenly distributed across the entire country. I'm in suburban New York City, and there's obviously a number of excellent places just up the road from us. But I also practiced in Charleston, South Carolina when I was in academics. We were the only academic center in the entire state, right? So I think it's really important for participation that all physicians allow their patients, no matter where they are, to be able to do that. So feel free to reach out to me correctly. And then he had another question about, he said, had one more question as well. If I heard you correctly, the Atlas study was done for patients with low-grade intermediate risk bladder cancer. How do you identify this patient population if they are not undergoing a TURBT? So it's a good question. As I mentioned to you, TURBT is never going to go away because you need to have an initial TURBT to understand the grade of a patient, right? High-grade patients are much more aggressive. They can jump and spread much more quickly. Low-grade patients, as Tom alluded to at the very beginning of the talk, they don't progress very often, but they do recur very frequently. So patients who went on Atlas had to have a biopsy first. For recurrent patients, they could have been patients like Donald who'd been having bladder cancer for years and had low-grade disease. And so all patients required a biopsy first to ensure that they were low-grade. And then the intermediate risk bladder cancer is really defined by 3 different criteria. One is that the tumor is large and low-grade, so greater than 3 centimeters. The second is that it's what's called multifocal, meaning it's in multiple different spots in the bladder, not just one spot. And the third is that it recurs within a year. So any patient with low-grade cancer that meets any of those criteria, size, number, or recurrence, becomes intermediate risk. All patients had to have a biopsy first to ensure that that was true, that it was low-grade first. So a great question, you got it. And again, we want to make sure that this drug was studied only in those low-grade patients. And so there are obviously other drugs for high-grade patients. This one is really for that subset of low-grade patients that recur frequently. Thanks for the question.
Any other questions did you see, Dr. Prasad, that were directed to you?
I don't see any.
Well, I wanted to thank all 3 of you, Donald, John, and Dr. Prasad, and participating this evening. This has been very educational, and like I said, from a patient perspective, it's really great information. And again, thank you for your time.
Thank you.
My pleasure.
Have a good night, everybody. Thank you again.
Thank you. Good night, everybody.